Let me very briefly introduce what I'm going to chat to you today, and I really appreciate the opportunity to be able to speak. The lecture really, as you can see by the title, is called Bad Mouth, Bad Brain. And really what we're looking at here from a point of view of understanding systems thinking medicine is really how the health of the mouth can determine. We're going to talk a lot about the health of the brain, but I also want to give you and show you the science where if the mouth is not healthy, then generally that can have significant consequences on the health of the body as well. Now we're going to be very specific to regards to the health of the brain, and we're going to be very specific to get some of the newer understandings of where we are with regards to cognitive decline, Alzheimer's. And we're going to be very specific towards certain bacteria, oral bacteria, and how they can influence brain health. I'm going to explore some new concepts with regards, well, certainly new concepts maybe of how we're applying them, but certainly not new concepts in the science. And I'm also going to show you some case studies as well today, of some of the work that we do and some of the work that I've developed. Now, next slide, please.
Coming.
I don't know if you guys know this place, but this is the Book Institute. So this is about an hour north of San Francisco, in a place called Novato. And the reason why I put this picture up, because it sort of frames my journey as a clinician. And this is me arriving at the Book Institute in 2016. I had been in clinical practice for about 20 years at this point. I'd done all the IFM training. I was an early adopter of the Institute for Functional Medicine, been through the certification process, and had been working with that for quite a number of years before. This is 2016, first morning at the Book Institute, and this is me arriving to do the early President training. I've actually done the President training twice. And again, I don't know whether you're all aware of the Breslin training, but it is Professor Dale Breslin's research and program. As you say, he's one of the founders of the Book Institute, but he's also a professor at, I think it's University of San Francisco. And he's, I believe. Okay, he's actually had 4 published papers now looking at a protocol that is designed to really influence the progression of early stage Alzheimer's, but people with subjective cognitive impairment and mild cognitive impairment. And so I've been utilizing that protocol now with my systems thinking training, IFM training for a good many years now. And so I want to show you some of that today, but some of the amalgamations of how we work through patients, but also some of the concepts that are really important that go with that. Next slide. Susan, just on a quick one, can you just see whether your mouse will go down to that section? Because this is a triple slide and I don't think it's going to work. If you come right down to the bottom where it's got the bottom right, where it looks like a little square with something dangling from it. If you push that, it'll take me into the full presentation.
First of all, okay, good. I got, it just goes down to certified practitioner.
Yeah, if you come down a little bit more, can you see where it says notes, comments?
Yes, I do.
If you press the square, not the notes, but see where it says this, keep coming along. There's like 4 dots. It's the one after that. Next one. If you press the next one after that. So this one here, if you click that, that's going to take you into full presentation mode. Brilliant. Okay, so when I ask to click through, it will click through all of these. And so my work with regards to working with people with cognitive impairment or early stage Alzheimer's is that what we've got to be able to do then is start to use, and I want to give you just a taster of that, how we'd work with someone. This is CNS Vitals. So this is a neurocognitive American company. It's a neurocognitive platform that we use. And the reason why we use this is because it's a very well scientifically validated piece of technology that allows us to look at how someone's brain is performing. The reason why that's so important is because what we get to do there is objectively get data points on patients rather than subjective. information from patients. And this is one of our patients. He's a 50-year-old male, 58-year-old male. He's actually in pretty good shape. He has no real sort of health issues at all. He's really coming to me because actually he wants to optimize his age and optimize his longevity. But he does have a few issues with regards to, he's not very good at people's name. That's increasingly getting worse. And he's doing a lot of word searching, if you like, in his brain. He's not finding the right words. And as you can see on there on his verbal memory, that absolutely fits his verbal memory scores, which are 2 standard deviations away from what we'd expect to see for a male of that age. So what we're seeing here is just a bit of the sort of data and a bit of the technology that we're using to start validating. And also for many people, their first, I call it the line in the sand from a point of view of how well their cognition is actually doing. And so that's something that we utilize quite a lot as to give us some benchmarks. Next slide, or next click.
I can't change it.
You should be able to do the next click, and that will move on. Thank you. This is another test that we use quite a lot when we're working with these patients. And this is a genetics panel that has been built from a South African company. We use this one quite a lot. It's a really good gene test that allows us to build a deeper picture of when we're looking at patients. And so the same chap, I just want you to just work with me on as I go through some of the data. As you can see on this chap, he's ApoE3E4. So this is the gene that is most associated with Alzheimer's. And as you can see there with an E3, E4 genotype, that puts him at around about 30% increased risk above a normal population. So then it is the gene most associated with Alzheimer's risk. Now, that doesn't ever mean to say that you go on to get Alzheimer's, but it is an increased associated risk. What is fascinating about this chap, and just to give you some idea of the letters that you can see there, N, M, and A, N is the genes most associated with neurodegeneration. So dementia, Alzheimer's, etc. M is associated with mood disorders. And what you can see on there is how this patient has a very pro-inflammatory risk panel from a point of view of genetics. This is a patient who is already by gene and gene variants predisposed to pro-inflammation. What you can also see on there, so if I was looking at this patient,
I don't think we should be eating Subway.
So what I would look at this from a point of view of when I'm looking at this score, this is a patient where we need to make sure that the lifestyle has to be anti-inflammatory, and also look at the appropriate biomarkers that are giving us indications of whether this inflammation is playing out. So what's quite interesting about this as a slight subset to this is that when you're looking at his risk of depression, you can see that his risk of depression is pretty much related to inflammation. And this is starting to back up all the evidence that we're starting to see, because very recently, a group of scientists at UCL, which is a major teaching hospital in the centre of London, they did a meta-analysis looking at the serotonin hypothesis that we've been using to treat depression for the last 3 decades. And what is clear in all the evidence is that there is no conclusive evidence at all to suggest that serotonin is at the root cause of depression. What we are clear about is that inflammation, excessive inflammation, drives sickness behavior that drives depressive symptoms. And so for many of our patients, they are depressed because they're inflamed. And this is a patient who may have susceptibility not only for neurodegeneration, but also for mood disorders like depression, because they are more likely to be underlyingly at more risk of inflammation. Next slide. So this guy is a chap that we want to make sure, based on his gene data, based on some of the signals we're getting from his neurocognitive scores, that we start looking at various aspects of his lifestyle and generate an anti-inflammatory lifestyle for him. If we're looking to the dietary aspect, here's where we can start looking at, well, what are the major players with regards to anti-inflammatory nutrients? And maybe it's a good idea for us to have a look at that. And so here's his fatty acid panel. and it's a very basic fatty acid panel, but as you can see on there, one of his major anti-inflammatory nutrients isn't there in anywhere near the amounts that it needs to be. So we're already seeing maybe significant risk factors building and building and building with this patient. Now, not only is that the case, we can see there on the omega-6s, they are nowhere near where they should be. Now, many people talk to us with regards to omega-6s are just pro-inflammatory, and the refined omega-6s are, but the unrefined omega-6s that would come from plant foods, and again, depending on the quality, are very anti-inflammatory, and they're processes that we need to work on. So with this patient in particular, it makes sense that we need to, which we did with this patient, is we needed to supplement him on anti-inflammatory omega-3 and some degree of omega-6s to bring him up to more defined levels. And of course, if we're doing this, then particularly the omega-3s, they have the capacity to calm down some of those genes that are predisposed to inflammation. So the key point about when we're doing genetics is we get the predisposition, and then we have an understanding of how we can build a program that allows the chemicals in the omega-3s to be able to talk to the genes that keep them quiet.
I'm less enthusiastic.
And of course we can do that as well with other anti-inflammatory compounds like curcumin would be something else that we could utilize
going
here.
up a lot.
Next slide.
And getting great returns, then
So
it might make sense.
Sorry,
Can we
But
have the
there's
person
massive fees
discussing your stock
your investments are
portfolio
paying
to mute
zero.
herself?
Susan Gibson.
Thank you. And so I've had the capacity to use the Breslin protocol for many years now. And what I would say on this, like every complex condition, whether this is cognitive decline, whether this is another disorder like obesity as an example, these are multi-complex conditions that need multi-complexity treatments. And what I would say on that is that we've had successes with the Breslin protocol, but we've also had some failures. And the reason why I think we've had the failures is because patients have to fundamentally change their lifestyles. And it's not an easy thing to do, and it's not a quick fix thing to do. But here's a great example. This is a 60-year-old male who come to me again, really healthy guy. He's done very well in his work life, and he's thinking about the next 30 years. And so he really just wants to optimize his health because he wants to optimize his living while he still can. So one of the things that he noted was that he didn't feel as though his memory was as good as it should be. And with our sort of workup at the beginning, we obviously noted that he was E3, E4, even though there was no dementia and no Alzheimer's in the family. Of course, that increases his risk. And when he did his first cognitive platform test that you can see at the top, this guy was 3 standard deviations away from age and sex matched results. So this is a very strong signal that this chap has got something going on there with regards to memory and his brain. But incredibly compliant guy, did everything that we told him, and within 16 weeks, he's already starting to show a brain and a memory function that is significantly better than it was before. So my point about this is that given compliant patients, given a really well-structured program, you can start to make significant differences to your patients. Next slide, please. I want to take you back to that 2016 picture where I arrived at the Buck Institute. Because not long after that, I started having a problem with a back tooth. And so off I went to the dentist. I've never had any problems with my teeth. And in fact, I think I've got pretty good teeth, but definitely a problem with the back tooth. So I go to the dentist and had a discussion. And this is the dentist that I've been going to twice a year, as well as a hygienist twice a year. Never had really any problems with my teeth. Sure, I've got a little bit of gum recession at the front, but the way my mum told me to clean my teeth, I'm surprised I've got any gums left at the front. But when I was working with the hygienist again used to say, well, you've got a little bit of plaque buildup, but it's nothing serious. So the dentist said to me, you know, we're going to have to take that back tooth out. So I said, okay, well, that's fine. Well, why is that? And she said, well, Mr. Williams, you've got some pretty significant periodontal disease, gum disease at the back there, and we're going to have to take the tooth out. So, of course, I sat there rather embarrassed that someone had told, and rather nervous that someone had said, well, I've got a disease. But I think incredibly embarrassment from the fact that, you know, for someone who's been in the health arena for nearly 3 decades, I had no idea what periodontal disease was. Absolutely no idea, and absolutely no idea of the consequence of it. And so I huffed and puffed back home, got straight onto PubMed, and this was 2016, and that really did open my eyes to the evidence surrounding gum disease, oral pathogens, and how that relates to systemic disease. And I'm going to take you through that tonight. And so I got very much digging into the literature because, of course, I've a very established chronic disease practice, functional medicine practice in central London. And I started to learn about how gum disease is very much associated with obesity, with type 2 diabetes, with rheumatoid arthritis, with Alzheimer's. And I think about all those patients that I've seen in the past where I never even asked the question. I never even considered that was gum disease and the consequence of it playing a part within their disease profiles. And so those patients that I did a good job with, I could have done a much better job with. And so that's led me down to become quite knowledgeable with regards to oral disease as it relates to other diseases. And so this is another thing that we use with all of our patients, regardless of whether they are cognitive decline patients, they could be any patient at all, rheumatoid arthritis, type 2 diabetic. But this is a classical, just simple oral pathogen test that we use consistently. It's an American company called Oral DNA Labs. And what you're seeing here is a test result of one of our patients, and we're looking at the pathogen risk with regards to what's happening within the mouth. Next slide. I want to bring you to this paper because this is the paper I still think still came out last year with regards to if you just want one paper that will bring you completely up to date with gum disease and other diseases, this is the paper to get. Now, when I do my presentations, I always make sure that the science I present are from studies that are free access online. So you can completely download this one. It's a really wonderful review. I think it's beautifully written. It's also beautifully illustrated. But what it does, it really gives you the story about how the mouth is connected to the body and how when things go wrong in the mouth, that can have significant consequences elsewhere. And we're going to explore that. What's also important about this is what we're learning about how our immune system reacts to ongoing invasion, particularly through bacteria, and how if there is a battle going on at the mouth with something like gum disease that goes on and rages for years on end, how the immune system learns and tries to make some decisions about, gosh, this has been going on for years. So maybe we've got to start going back to their bone marrow with the message that there's still a battle going on and start to produce more cytotoxic immune cells that can maybe finish the battle off. And this is what we're learning. So the more the battle rages with gum disease in the mouth, the more damaging some of the immune cells become. And so you get into this feed forward pathway with regards to if you don't deal with the gum disease or any other infectious attack to the body, your body is going to consistently create more inflammation. It's going to consistently create more immune soldiers that are even more damaging to the bacteria, but importantly, as we know, damaging to you. Because when your immune system responds to something like a bacteria, it does a really good job of killing the bacteria, but you're also going to get a more peripheral damage that goes with that as well. Next slide. And so that led me to the situation where I wanted to get a deeper understanding of how a body defends with regards to gum disease. And you've really got to look at this in two ways, because how we respond to infection or attack is two-pronged. how pathogenic is the virus or the bacteria, and then how responsive or not is the immune system. And so this, obviously I've been in the industry for quite a long time. I've got a lot of connections. And so I developed with a genetics panel DNA Smile. And what DNA Smile is designed to do, and it's not just DNA Smile, because we've developed a clinician's course that gives a much deeper understanding to clinicians about how to use DNA Smile within the bigger picture of systemic disease from a systems biology perspective. But the key thing to think about is that you can have an individual with a mouthful of pathogenic bacteria, but very little gum disease. You can also have an individual with hardly any pathogenic bacteria, but extensive gum disease. That's why you've got to understand, number one, who's on the battlefield, and how pathogenic are they from a point of view of, are we just dealing with new recruits, or are we dealing with special forces? Because there's a big difference. And then what we've got to learn, well, how does an individual's immune response choose to react to the pathogen? Because that is what elicits the progression of the disease. And this is very apparent of what's happened with COVID. And we're clear on that. It's not so much the pathogenicity of the virus, it's the way the immune system chooses to respond to the virus that, unfortunately, with a few other comorbidities thrown in as well, that unfortunately gives you the more serious consequences. Next slide. So look, here's what I would like to go and chat to you today. And these are some of the aims of what I'd like to get over. I really want to give you that understanding that local issues have systemic consequences. So the mouth and the health of the mouth really does influence the health of the brain. I'm going to show you some new concepts in how we think about treating disease at our practice, which is a combination really, again, of getting a deeper understanding of how your body is in a consistent battle and how your immune system responds to, from a point of view of the host, to pathogens such as bacteria. And really testing the battlefield and learning about our defenses is part and parcel of the DNA Smile genetic profiler I developed, and I'll talk to you about that as well. But I also want to concentrate on one bacteria in particular because it simply had the most studies done on it, and that is Porphyrovirus gingivalis. I want to give you a really dig into the literature with regards to that bacteria and how much of a pathogen it is. But remember, it's not just its pathogenicity, it's how that immune system is going to react as well. And I'm going to throw some case studies in there as well to just showcase some of this. Next slide. So why does the mouth matter in Alzheimer's disease, and how can a local disease have a very systemic effect? Next slide. This is, again, free access online, really great paper. This is David Furman, who's actually at the Book Institute as well. And he's got a really stellar group here that have really wrote a really nice paper in 2019. And the real synopsis of this paper is that all diseases fundamentally are inflammatory led. It is one of the major processes that drives disease. What's also interesting about that is, therefore, most diseases are interconnected because they're underpinned by some of the underlying mechanisms that drive disease. And the major player that seems to be in the literature is inflammation. Now, what's really important about that, it means that in some way, shape or form, when you get patients with comorbidities, I'll give you an example, a type 2 diabetic patient who's also obese, you may be able to treat two diseases in one go, or certainly reduce the damage or the progression of two diseases in one go. Because if you deal with some of the underlying mechanisms like pro-inflammation, you're going to be able to make real influences on some of these disease processes. And so again, really wonderful paper explaining how, and again, how we think as systems thinkers is not a question of, well, what is it the disease that we've got to treat? It's more about maybe we should think about treating some of the underlying mechanisms that are driving the diseases. And if I take you back to that patient that we saw at the beginning, that is a patient that by genetics is predisposed to pro-inflammation. So if you have a patient that is predisposed to pre-inflammation, you have an inappropriate lifestyle, you're physically inactive, you may be overweight, you might have had a Lyme disease in the past, these are all things that may exaggerate that inflammatory response and also exaggerate the progression of disease processes. Next slide. And so I bring you back to the paper we talked about in Nature Reviews in 2021, because when we look at some of the associations, they're absolutely staggering from a point of view of the risk. Obesity, cardiovascular disease, hypertension, autoimmunity, Alzheimer's, rheumatoid arthritis. I also just want to talk about a new one that we're seeing again in the literature, which is again is fatty liver disease and its association with gum disease. And I'm going to just talk about the underlying mechanisms as we go forward in this section. Next slide. So I suppose the question, what someone said to me once is, well, yeah, Pete, but why are you so interested in gum disease? And I think this is the slide of why I'm so interested in gum disease. A very recent journal just 2 years ago, looking at how many people have gum disease. And if we look at Western societies, and particularly with high income countries, over half of the population has gum disease to some extent. So what we're knowing on this is that you'll have some people who are asymptomatic and don't know they have it, but it's quietly working away. And you'll have some people who are having real problems and maybe at an early age. And so this is why it's so important for me, because when patients come into the clinician's room, I've got to make an assumption that if I'm dealing with a patient who may be at risk of Alzheimer's or rheumatoid arthritis, knowing the literature showing the increased risk associations, I have to at least ask the question about whether they have gum disease, because that gum disease is a player in exaggerating other disease processes, and the numbers are staggering. And what's really quite laughable about this is that the higher income countries have the worst gum disease. I think that says a lot about probably the way we live and how we choose to eat, but pretty staggering. So this is why when I developed DNA Smile and oral testing, bacterial testing in practice, it's not something that you need to do occasionally. It might be something that you need to do with over half of your population that comes into the clinician's room. So it's very, very prevalent in the literature. Next slide. So let's look at that. Let's look at periodontal disease and Alzheimer's. Let's make that connection. Again, very recent paper done last year, which was a large systemic review. So we've looked at lots of papers, and just here's the conclusion here is that, and again, I'll just read the last sentence there, is that the treatment of periodontal disease could be a way to explore Alzheimer's disease prevention. So again, very large systemic review, lots of research with regards to periodontal view and its association with Alzheimer's, and we're pretty clear it's something that we need to think about and certainly look at, particularly if we're dealing with patients with mild cognitive impairment, subjective cognitive impairment, or early stage Alzheimer's. And I'm going to reinforce that message as we go forward. Next slide. Again, I just want to show you some of the links, not just with Alzheimer's, but look at the title of this paper from Diabetologica in 2012. Periodontitis and diabetes, a two-way relationship. These are diseases where the underlying mechanisms that drive both diseases are literally the same. So what does that mean? So if I have a diabetic patient that comes into the clinical practice, and I haven't asked about the gum disease, which I have to say 10 years ago, it wasn't even a consideration. I've missed a major component of something that may be exaggerating their diabetic control, their disease progression. On the flip side, what we know here is that if you can control the gum disease or make inroads onto the gum disease, you can also help the diabetic control. These diseases are underpinned by regulated immune response, by pro-inflammatory cytokines, by increased oxidative stress. You see it exactly on both diseases. So if you deal with the underlying mechanisms, you can kill potentially, or you can certainly help two stones. You can kill two stones in one go. Does that make sense to everyone? Okay, next slide. Again, for me, a very landmark paper, 2017. This was the researchers at Texas Tech and Vanderbilt. Why I think this is a really important paper, because they don't just, the scientists here don't just suggest that oral pathogens, but in particular Porphyrovirus gingivalis, is not just associated with the risk of cardiovascular disease and atherosclerosis, it is actually a causative mechanism in the development of atherosclerosis. So that's a big change, because what we're starting to suggest is atherosclerosis in part because of oral bacteria. Now, what are we talking about here? Let me just try and do this very simply. What happens with gum disease is that we lose an essential barrier. When we start having pockets developing around our teeth, when we start having bleeding gums, we have an essential barrier that has been compromised. And remember that from the mouth to the anus, that is a barrier that protects you from the outside world. Once that barrier is compromised, you're going to have what we call translocation of bacteria, moving from places that it should stay into places where it can start to cause trouble. So when you start to see oral bacteria floating around in someone's veins and our arteries, your immune system immediately attacks. And that creates increased inflammation, increased oxidative stress, and an upregulation of your immune system that ultimately starts to damage structures. And this is what we believe is one of the mechanisms that is related to the development of atherosclerosis. Okay, next slide. So taking those examples on board, I want to just develop some of the new concepts in treating disease that is in the literature. And I think these are expanding rapidly. And I would say COVID has been a major player in allowing scientists to start think from a systems perspective. How the hell does all this fit together? What are some of the underlying mechanisms that we might need to think about with regards to how we treat? Next slide. I just want to put a bit of context onto this. This is giving you the understanding about what a human being is. And humans are superorganisms. The term we use in the literature is called holobionts. Very simply, we are slightly more bacterial cells than we are human cells. And that's really important to understand, because what that means is that if we have a sick patient and we don't ever ask about the bacteria, then we're maybe missing 50% of the reasons why they're sick. So have we asked about the bacteria in their mouth? Have we asked about what's happening in their gut? Have we asked about what's happening in their sinuses? Have we asked about what's happening in the vaginal cavities? I can tell you from nearly 2 decades now of treating people, many people who come to see us who have been brilliantly worked up conventionally, but no one has asked the question with regards to maybe it's your bacteria that are sick and that's what's causing the problem. So this is a major factor for me. And honestly, when we see these people, we just go, has anyone looked at these? Because if you are over 50% bacteria and you've never looked into that, and all of the conventional tests haven't really brought anything up, then maybe you're missing a major component that's making you sick. Next slide. So here are some of the major concepts that I'm fully invested into with regards to our practice, and the literature is really starting to bear these out now. And we've just talked about this. And as I say to all my patients, given that we're more bacteria than human cells, surely it makes sense with sick people that we need to investigate systemic bacterial health, especially in the mouth. Next slide. Here again, very much related to me trying to develop DNA Smile, because I wanted to know, and that is that our immune response to invaders, and when we react to invaders, not only does our immune system try to identify and kill, whether it's a virus or bacteria, it also creates peripheral damage as well. So when our immune system responds, then it can also damage structures and borders that protect you as a human from the outside world. So therefore, knowing the sort of our genetic signature to how we are going to defend is really important. I wanted to know whether gum disease was a component on an individual where they just don't mount a robust enough immune response, or They mount a too robust immune system that's too much up for a fight and really doesn't like switching off when it gets going. Because when we're very clear on the literature with regards to long COVID patients and the severity of outcomes from that, is that the most serious cases, the deaths, etc., were predominantly in patients with comorbidities, already pro-inflamed, but also with very aggressive immune systems that would hyper respond and be not that keen on switching off. Next slide. So again, we talked about this, and I want you to remember when we were talking about how an oral bacteria like Porphyrovirus gingivalis can be associated and may be a causal factor in the development of atherosclerosis, because once you have a border is compromised, a structural border is compromised. And what I'm saying here, I'm not just talking about gums, I'm talking about stuff like leaky gut, and also I'm talking about leaky brain as well, because your brain has a blood-brain barrier. And when we're starting to look at the evidence with regards to Alzheimer's, what compromises the blood-brain barrier, that barrier that protects the brain from the outside world, is becoming super important in the literature. And indeed, we're leading to what is compromising the blood-brain barrier. And is that a component that is driving dementia, neuroinflammation, or Alzheimer's? But the key thing to think about here is that when you have a compromised border, it increases your risk for systemic disease, because you allow molecules, bacteria, to translocate from a local position in the mouth to anywhere in the body. And that is a key mechanism of what we're seeing from a point of view of disease processes in many diseases. And I'm going to show you some examples of that. I've got a really great case study. Next slide. Now, because imagine all these borders, whether it's the mouth, whether it's the sinuses, whether it's the small intestine, large intestine, whether it's the vaginal cavity, whether it's the blood-brain barrier, they are all in effect borders that protect you from the outside world. So in effect, they look not dissimilar to castles. Now, no two castles are the same, but they sort of do the similar thing. They protect you from the outside world, and they let things in that they want in, they let things out that they want. But the point about them is, because they're similar, when you have one border that is damaged, it increases the risk of other borders being damaged as well, because the mechanisms that damage one border are the same that damage the other. And so there's lots of emerging literature on this. But when you have a patient, of course, who comes in, and they are coming in for maybe cognitive decline, early stage Alzheimer's, or indeed other diseases or disorders, this is almost like sci-fi when you're speaking to your patients. And so you've got to really try and simplify the message. So here's, as you say, it ends up being a point where you've got to be a real good storyteller and even a little bit of poetry to an extent. So I try to sort of simplify all these new mechanisms by poems. And so I say to people, look, leaky gums and leaky veins, leaky guts and leaky veins. Because if you've got leaky gums, then your chances of having leaky veins, leaky guts, and leaky brains is substantially increased. Now, I just want to put some more nuances onto this, how this is associated with Alzheimer's disease. I'll put 4 papers down there. Again, you can download free access. I want to just point to 2. The Nature Journal, the 2020 brilliant paper that overviews everything that I've talked about here. So again, a really good paper to start looking at, so you don't think, you don't think, God, this guy's talking madness, because the data is there, the evidence is there, and the research is there. I also want to take you to the paper on the right, the neurological degeneration paper, the 2022, very recent paper. Why this one's quite important is because it also looks at ApoE4 genotypes. Of course, remember, with the Apo, if you have an E4, then you're more associated with increased risk of Alzheimer's. What that paper is noting is that ApoE4 genotypes, and some of you may know your ApoE status, just by that genotype are more at risk from blood-brain barrier dysfunction. So I just want to clarify and try and simplify what we're thinking about here, because the Alzheimer's research, and again, is becoming bigger and bigger and bigger. It's a bigger picture, it's multifaceted. But some of the key mechanisms that we're looking at that is driving Alzheimer's neurodegeneration may be that we have a compromised castle wall, if you like, a blood-brain barrier, and we're definitely seeing genotypes that are more at risk. I want to take a step back. This is where we're learning that if you've got leaky gums, then you may have increased risk of a leaky brain as well. So we're starting to think about how we underpin these, because then we can start about treating people, which means that if we have a patient who is coming to us from the Breslin protocol, they're at risk of cognitive decline, but they've got poor dental health, they may have a leaky gut, we need to make sure that we're trying to solve all of those issues. These are local issues that are far away from the brain, but they're all interlinked. This is how the system is all interlinked. Next slide.
Just keep doing that.
Now, trying to get this through with patients is really tricky, because when patients come to me and I start talking about gum disease risk, we get in a situation where they start saying, well, Pete, you know, with the greatest respect, you're not a dentist. Why are you asking me about my oral health? And what I would say on that is that it's been tricky over the years to try and get them to understand that, you know, there is not one mechanism that is driving one disease. It's a big systemic pitch, and we've got to think about everything. But what we did do is that we created this gum disease risk assessment form. And what that allowed us to do was actually just be able to, when the form came back to us, if it was showing any red flags, at least we could start the conversation. And this has been incredibly successful for us. And it leads us into building that storyline and that conversation that what is happening in your mouth may be driving some of your other disease processes. Next slide. This is a really great example of, I want to take you back to Thurman's paper with regards to all diseases may have an underlying mechanism of inflammation. But if you understand the mechanisms that are driving similar diseases, and there's a very strong relationship between oral disease and rheumatoid arthritis, that if you treat one, you may be able to treat another. I'm going to take you through this paper because it's only a case study, but it was a case study that had such significant outcomes that myself and the dentist there, Victoria Sampson, we wrote this up and we presented this at the big IFM international conference last year. So I'm just going to give you a background on this one, and it will give you an understanding of what we're talking about. This was a patient that came into us with advanced rheumatoid arthritis. And she'd actually been under a functional medicine clinician for over a year. They've done significant interventions, they've done significant testing, but her rheumatoid arthritis wasn't getting any better. And in fact, it was getting worse, even with all this intervention. So naturally, she was just, and she is probably one of the most compliant patients I've ever had the pleasure of dealing with. And so when she came to me, obviously, she just wanted a difference of an opinion because she'd been spending a huge amount of money and really her rheumatoid wasn't getting any better, it was getting worse. And so when she came to me, there was one clear red flag for me. And again, no fault of the other clinician, because 5 or 6 years ago, I wouldn't have asked the question otherwise. But that question was, did you have gum disease? And she had very significant gum disease. And so basically, whilst I did another workup with her, we focused with Dr. Victoria, we focused on dealing with the oral disease. And we used some really sophisticated technology here. We used oral bacterial testing because we wanted to see the pathogenicity of the bacteria in the mouth. And we used a new DNA SMILE genetics panel because we wanted to see, were there some genes much more associated with not just her advanced periodontal disease, but also how that may relate to other disease processes. It took us 4 months to take this patient from someone who had quite significant rheumatoid arthritis to completely in remission. And even years later now, based on the fact that we've consistently gone on top of the gum disease and we've kept it stable, she really doesn't have any flares at all from rheumatoid arthritis. She doesn't take any medications, and she has a protocol that we give her. We test her occasionally, but she's really solid. She doesn't show any outside signs of rheumatoid arthritis. Now, it's a case study. So again, we could say, but this is the lowest form of evidence. Completely appreciate that. But this was a life-changing case for this lady. So we were very confident again that what we did here is that we treated the mouth to treat the rheumatoid, and she had very successful outcomes from that. Next slide. So I want you to remember that your body is consistently defending against the outside world. It's trying to protect you, and it has barriers to do that, and it has immune system, and it has bacteria to do that. But your brain does exactly the same. And this is about understanding that the brain has its own immune system, but it also has these physical barriers, the blood-brain barrier being one of them. And we want to make sure that that's not compromised. Next slide. So, again, the literature, as we learn more, our understanding of diseases like Alzheimer's changes, or certainly we get a bigger picture of it. Because there is an argument that for many, the reason why they are, if you like, losing their minds is because they have an infectious disease in the brain. And the brain is trying to defend against these infections. It could be an oral bacteria. It could be some of the components of Lyme disease. It could be some of the herpes simplex viruses. These are all pathogens that the brain has to defend from. So again, very interesting when if we take you back to 2016, what I love about the sort of summary on this paper, when we're looking at some of the sort of Alzheimer's disease addressing the role of spirochetes, which are these sort of bacteria that have their sort of twiggly tails, is that we learn that when we look at the brains of deceased Alzheimer's patients, we find lots of things in there, particularly bacteria. And therefore, again, when we're looking at that, we may consider Alzheimer's as an infectious disease. And for many of people, this may be the first and most important consideration we need to think about. We need to think about, can we identify the diseases? And then how is the brain going to defend against that? Because if we do nothing, the brain and the brain's immune system is always going to defend against that. And when your immune system works, it increases inflammation, it increases immune activation, and it increases oxidative stress. Certainly the two main players that consistently damage the brain. So, next slide. Very recent paper, really look, and again, this is probably, if you want to understand what are some of the leading causes of how Alzheimer's may be seen as an infectious disease, this is the paper to get free access online, and it will give you certainly evidence of what we understand may cause a sort of an infective process against the brain. And what's interesting about this, of course, is that COVID, it seems to be a major player with regards to an infective process on the brain. And of course, when you're dealing with COVID patients, and in particular long COVID patients, we absolutely see almost in many of these the brain dysfunction, the brain fog. Now, I look at that and I think, as we see quite a few long COVID patients, and I'm pretty sure that they've probably got some degree of neural inflammation going on because the brain is trying to defend against these pathogens. Next slide. And again, beautifully illustrated on this journal, giving you an understanding of maybe how the brain reacts and how the microglia, part of the brain's immune system, responds. And you can also see, again, the key about this is, on very simple terms, is that we're trying to make sure that infective agents or pathogens or invaders don't get to the brain. Because when they get to the brain, they are going to have to respond. Your immune system always responds to things, but it's non-discriminate, and it just does a very simple job that increases inflammation, increases oxidative stress, and there's really two processes that really damage neurons. Next slide. So I'm going to bring you back to Porphyrovirus gingivalis, which is the most studied oral bacteria, pathogenic oral bacteria. And I'm going to look at that with regards to not just Alzheimer's, but also systemic disease. Next slide. And as you can see on this diagram here, Porphyrovirus gingivalis is very much associated with all the major chronic diseases, from type 2 diabetes to obesity to dementia to musculoskeletal health to cancer. And as you can see there, a lot of research with regards to adverse health pregnancy outcomes as well. Next slide. What we also, again, just trying to keep this specific, is looking at porphyromonas gingivalis in Alzheimer's brains. And of course, what we've learned about porphyromonas gingivalis is that it has these toxic proteases in them called gingipains. And when gingipains get into the brain, they really do create some trouble. And so what we're trying to make sure that we're trying to do is, again, bring it back to source and make sure that there's not a lot of porphyromonas gingivalis hanging around anyway. And we're trying to shore up the borders so that they don't go through. You don't want them with easy access, because porphyromonas gingivalis will also damage the blood-brain barrier as well. Next slide. And here's one of our patients on one of their tests. I'm going to talk about this patient later on because she's really a canary in the minefield. But as you can see there on testing, very high levels of porphyromonas gingivalis, and she has very much a predisposition for Alzheimer's disease risk. She's not specifically showing signs, huge signs of cognitive decline yet, but we need to get onto her early with a protocol because she has very significant risk factors. And what we don't want to do is we don't want to allow those to play out over time. Next slide. So this, I think, is a very important paper. I'm going to explain this in a minute, because what you're seeing here, again, just look at the title of this. Again, when we're talking about Alzheimer's disease, and we're talking about, well, is Alzheimer's in part an infectious disease with some genetic underpinning to it? I think the answer to that is, well, absolutely, based on the literature. Look at the title. Porphyromonas gingivalis is a strong risk factor for Alzheimer's disease. They've got a beautiful diagram really giving this understanding of why it is. It's about, again, it's about loss of border control, and it's also about how the immune system responds to an invader. Now, when you put on that shared risk factors, again, maybe polymorphisms that increase your risk of immune activation, of inflammation, when you stack onto that comorbidities such as obesity, such as atherosclerosis, you start to see these multiple additive effects. And so they all enhance the risk that you're going to see neuroinflammation, and you're going to see neurodegeneration, and then ultimately you're going to see cognitive decline. Now, if this is ongoing, you're also going to see an immune system that primes itself. It tries to get more and more, if you like, cytotoxic, so that it becomes more and more destructive to both bacteria, but also to body at the same time. Next slide. This is where I think this is really important, and this is something I'm very keen to get out there. I really love what the review said here. I want to take you back to gum disease, because what we've learned on gum disease, for most people, gum disease is actually a disease that can start really in your 20s. For most people, it will be asymptomatic. And if I take my case of understanding that the first time I knew that I had some degree of gum disease was at 45, I was completely asymptomatic to that point. So I had no idea that probably gum disease had been bubbling away for probably 2 decades. What we know on gum disease is it comes early. So you can have individuals in their 20s already getting gum disease. For many people in their 40s and 50s, they've got very well established gum disease. But what we've learned is with Alzheimer's in general, it is a later onset disease, although we're certainly learning that actually we're starting to see more and more people getting diagnosed with Alzheimer's in their 50s, and we weren't seeing that a decade ago. But the point about this is that if you had the capacity, we've got these two sort of periods where gum disease is established, Alzheimer's disease is established. Let's assume that we have a patient with gum disease, and for 2 decades, they get their toxic brain insults from porphyromonas gingivalis that stimulates neuroinflammation, that accelerates the risk for Alzheimer's. We have this beautiful window to treat decades before we get to Alzheimer's. And this is one of the key things, again, that I suppose is difficult to say to people, because most people only do something about something when they've been diagnosed. And what we're saying here is that maybe treating gum disease much, much earlier and really putting priority to it not only saves your mouth, but also maybe saving your brain as well. And you've got this window of opportunity. And I can tell you from me being in this role, from someone who had really well-established gum disease and has developed all these strategies to go with it and a DNA panel, I've taken my gum disease from being really quite advanced to being very moderate. Now, it's something that you're going to have to look after every day because it's a risk factor for me. It's probably my weak spot, but I've reversed one disease, which means that hopefully what I'm doing based on the literature is really trying to reduce potential toxic assaults on my brain because I've looked after the mouth. Next slide. Does that make sense to everyone? What is interesting, I think, about what we're talking about here is that the pharmaceutical industry are definitely having a look at this. This is the GAIN trial, and I think they're certainly into second phase trials at the moment. And what they're trying to look at is develop a drug that actually inhibits the toxic proteases of Porphyromonas gingivalis. So again, I think when you look at that and when you look at the fact that the pharmaceutical industry are very interested in this feature, we should be thinking that we may be onto something here. Next slide. So again, you can go online and you can have a look at the GAIN trial. Again, it's definitely ongoing, but I just want to be clear on what they're saying here. They essentially want to create a drug that interferes with the toxic effects of some of the oral bacteria because they know the damage that this oral bacteria can do to the brain, and that's where they're looking at. So we'll see how they go. I think there's a few things to think about. And drug therapy for Alzheimer's hasn't had a good history. What I think is interesting about this is that it feels like this is better systems thinking. And this may be something that is appropriate with an appropriate patient later on. I suspect they're going to get good outcomes from this. But what we obviously don't know is we don't know what the side effect profile looks like on this side. But really interesting. And what it does, it backs up the evidence that we've just talked about there's definitely something here that we need to think about and work on. But look, there's a very simple aspect to all of this, is that we just need to think about looking after our mouth and our teeth in a slightly better way. Next slide. So I'm going to introduce you to DNA Smile. This is something that I went on to develop with a genetics company, but also with some really great professionals as well. Next slide. I'm just going to give a shout out to two people. Helen Gouch, she is a dietitian by trade, but she is a nutrigenomics expert. So she is expert in understanding nutritional genomics and how they affect people. So what I originally did in association with DNA Life and Nordic Labs is that I had all these ideas, all the things I wanted to look at, the processes and the underlying mechanisms that I wanted looked at. But Helen was the one who took my ideas and actually went away and researched the most appropriate gene variants associated with gum disease risk. And so what is really important about what we developed is that every gene that we've looked at, there is a lifestyle intervention that reduces the effectiveness of that gene work in that gene variant. And so we know that every gene that we've looked at, we have the capacity to either slow it down or accelerate it based on lifestyle, and that reduces our risk of gum disease. And also Dr. John Roberts, who is he's a biological dentist, certainly very well renowned in Europe, if not in the US as well. And he's just a brilliant guy for me to throw my ideas against, particularly around mercury. And I'm going to show you a little bit on that. We're not fully down the road. And again, I still think for me, like everything, DNA Smile is a work in progress. I think we've done enough where we can send off a panel, and we've developed a clinician's course as well to give a much bigger picture of understanding where DNA Smile fits with regards to gum disease, but systemic disease. But it's still very much a work in progress. Next slide. So when we're dealing with people and we're dealing with DNA Smile, again, I want to bring you back to the simplification. We want to know two basic things. Who is on the battlefield? and how pathogenetic are they? And as you can see on this, again, it's one of our oral pathogen tests. Dead easy to do this one. It literally, when patients come in, as long as they haven't eaten or had a drink for 30 minutes, you can just swab them 30 seconds, spit it out, send it off to lab. Brilliant and easy to do. And as you can see on this, again, one of our patients with not too bad with regards to high-risk pathogens, but some other moderate risk and low-risk pathogens there. And just to let you know that the black lines are associated what we call the therapeutic threshold. So the black lines are where we see what the American the American Dentistry Association assume is moderate periodontal disease. Next slide. So we use those a lot. And this is me simplifying DNA SMILE, because what I wanted to do is I wanted to get an understanding of how our immune system, both innate and acquired, is going to respond, and what does the signature look like. And we also threw a few other things in there. Number one, we wanted to put sweet tooth in there, because again, sweet tooth and the more predisposition for sweet tooth means that we may be seeing more individuals who are more likely to want to eat more highly refined sugars, and that alters the microbiome in the mouth and also alters the sort of the profile from good to bad bacteria. But also the lipid metabolism detoxification is associated around mercury detoxification. Next slide. And really, here's a sample report that we've done. And really, this is, again, getting that understanding about how our immune system chooses to defend against the outside world. Again, one of our patients here, as you can see, predominantly we're going to see a very much an increased inflammatory-led response. So we're going to see a hyper-responsive inflammatory response, and we're also going to see some changes with regards to some of the interleukins that are also associated with other diseases, but also autoimmunity as well on this side. Next slide. Now, this is a big question, and I have to say, I've done a lot of study on this. I've also done a lot of conversations with, I think, some quite prominent people, some prominent dentists. I think we all agree that maybe mercury amalgams are not the best thing to have in our mouth, and we should probably get rid of them. But the situation is incredibly more nuanced from that, because what I've learned is that you can't just take them out. You have to have a strategy that allows you to know, well, if we take it out, what are we going to replace it with? You know, because when you take a tooth out, you need to think about, well, is it going to be replaced? And how are we going to replace it? And maybe what we put back is something that is actually not going to be as good as well. And so these are all the nuances we've got to think about. But what I wanted to do is, because I get asked by patients a lot, should I have my amalgams out? And what I say to them, well, number one, are you symptomatic? And number two, maybe we want to give you a better understanding that maybe your genetic risk is high. And then that gives us a better understanding of, okay, maybe this is a smart thing to do with the appropriate dentist, because there are quite a few increased risk factors here genetically. So again, this is where we learned that the ApoE4 genotype definitely increases your risk of potential problems with mercury amalgams. We're definitely clear on that. It's one of our patients who actually unusually has an ApoE3E2, which is highly protective for him on that. But as you can see there, from a point of view of detoxification, they've got some very significant SNPs with regards to the way their body detoxifies. And so we might be looking at a patient here who may be at increased risk. So again, I don't think I've got all the answers on this one, but I think what I've got here is I'm trying to build a sort of more significant sort of clinical relevance sort of discussion with my patients to say, well, maybe there are more consequences that we need to think about, and maybe it's a good idea. But what I would say on that, of course, the risk from a point of view of mercury extractions is whether you get extracted with in the right way. And there are not a lot of, well, there's certainly an increasing amount of dentists who we know are called smart dentists. These are dentists who've gone through the appropriate training to understand how they should safely remove mercury amalgams. Next slide. Again, when we're talking about more different gene variations, here's another one of my patients. And as you can see here, very significant risk of Alzheimer's because they are ApoE4/E4. Now, depending on when you're male and you're female, this is actually really quite a significant risk factor. And again, looking at the literature on lifetime risk for developing Alzheimer's disease, just based on that gene alone, particularly in females, you're talking very significant risk, 60% or plus on that. So it's a very significant risk factor. And again, and why is that? Is because we know that if you have an E4, which again, as you can see here, the housekeeping proteins, they just don't remove things well. So they don't remove oxidized lipids very well in the brain, and they don't remove toxic metals very well. So again, if I had an ApoE4/E4 patient with a mouthful of amalgams showing risk factors and symptoms, and with a family history, then there's definitely a conversation to say, okay, maybe we do need to take you down a strategy to start reducing this load. Next slide. And I want to take you back to that rheumatoid arthritis patient, because here's her radiographs. And as you can see there, she's got very significant bone loss because she has very advanced periodontal disease. Again, 40% bone loss. So she's lost a lot of teeth already, and she's losing a lot of gum and a lot of bone. And in a sense, she's got a castle wall that has so many holes in the bacteria are slipping through and causing problems in many places, not just her brain, but we definitely know there's an association with oral bacteria and rheumatoid arthritis. So we know some of the mechanisms that drive the joint issues can be the immune system response to bacteria that have translocated out of the mouth onto the joint surface. Next slide. And this was a DNA Smile report, or certainly some of them. And what you can see on there are some really significant indicators of why she's got significant periodontal disease. I just want to talk about it too, but I just want to talk about, and also how, when you start to have significant results, how they compound each, that again sort of builds the fire. So not just one gets compounded on another, we get this amplified signal. So we certainly know there's a very strong relationship between IL-17 and periodontal disease, but also with other diseases, and in particular autoimmune diseases. So we know autoimmune inflammatory, which is classically what rheumatoid arthritis is. So we know we can see the link between oral disease and rheumatoid arthritis because we've got a gene variant that increases her risk. Now, it's amplified, the inflammatory response is amplified by IL-1, and she's got a very significant SNP on IL-1. So not only is she at risk of more pro-inflammation here, periodontitis, advanced gum disease, it also increases her risk of autoimmunity, but also coronary artery disease, diabetes, and obesity as well. She also has another SNP that I wanted in there, which is MMP3. And what we've learned on MMP3, it's a sort of matrix metallinase protein, and it's involved with sort of breaking down the extracellular matrix. And really extracellular matrix is anywhere where you sort of see these sort of collagen structures. So, you know, what you'd expect to see in joints, what you'd expect to see in the skin, but also what you'd absolutely expect to see, really what your gums are. They are sort of a mixture of collagen fibers and other aspects. And she has a very significant SNP there. So that means that she's much more at increased risk of gum recession because of this gene. And when you amplify that with IL-17 that is pro-inflammatory, and IL-1 that is very significantly pro-inflammatory, and IL-1 seems to be this anchor point for all other pro-inflammatory cytokines. It seems to amplify the signal and talk to other pro-inflammatory cytokines. You can understand why this patient has got into the situation that she is. Now, one of the other things, again, that we learn, again, when we're thinking about a systems perspective, is that she's got some reasonable SNPs around vitamin D. And we've done a lot of work on vitamin D with regards to genetics, and you'll be absolutely surprised at how many people seem to have huge amount of gene variations, not just from a point of view of, again, taking inactive vitamin D is what you get from the sun, but how it's transported down to the liver, it's made into active vitamin D, and then it gets on the vitamin D buses to be taken to the cells. So we do a lot of vitamin D genetics, and we find many, many patients have significant gene SNPs, and that follows the history of them never really sort of having a really good summer and really never getting their vitamin D levels up to what we would consider accepted levels. Now, vitamin D not only helps to modulate and calm the immune system, helps it be less reactive, it also is very much important with regards to localized and oral immunity. So again, you can understand when we're working with patients just on the oral aspect, how you can sort of get all these figures and really bring all of these genes together to get a much more personalized and individualized protocol. Next slide. And we're even in a situation because we've dug into the literature where we can make some suggestions. So again, anyone who has a gene variant like MMP, where they have, a much greater risk, they're also at obviously greater risk of anything where we're seeing the sort of the collagen matrix, skin, joints, etc. And so we can start to sort of think about, well, is this a patient where we should be looking at their diet? We should be optimizing maybe something like collagen supplementation. Should we be making sure that their protein levels are sufficient enough? And these are something, again, where we're personalizing the data based off the gene and results. Next slide. What I'd also say just on that, I just want to talk about MMP9, because MMP9 is another matrix metallinase. We're definitely seeing evidence that people with MMP9 problems also very much influences the blood-brain barrier. So people with more activation of MMP9, which comes from more activation of MMP3, can have more disturbed blood-brain barrier problems. And of course, that increases potential risk for neuroinflammation and also increases risk for Alzheimer's. So we're still developing DNA Smile. It's an ongoing process. It's available now, but and there's certainly the trainers available. But I'm very keen to understand how it all fits together. And so we also look at stuff like toll-like receptor 4, really interesting sort of frontline way your immune system tags things and decides whether they are friend or foe. But what's very interesting about this is that many people are moving over to very high saturated fat diets, keto for many people, and people who have gene variants on toll-like receptor 4. Let me just talk about toll-like receptor 4, because it's like an early signaler with regards to, is there trouble on the battlefield? And it sees saturated fat as a pathogen. And so when it sees saturated fat, and if you have an individual who's got a high fat diet, it will be hyper responding and signaling to the immune system to upregulate itself. So again, this is where we can start to get more personalized data that can allow us within each individual to say, maybe this is the diet that we should be using for you, or certainly be aware of how much saturated fat is in their diet. Next slide. And again, very simple, DNA Smile. It's all online. It's dead easy to do. You can do it in a day. We've got it all set out. And it really just gives you that very simple underpinning of how it works and how you can apply it in clinical practice. Next slide. Okay, so listen, I'm hugely grateful that you're all hanging on in there. I'm going to go through a case study with you to give you an example of how this all fits together. This is a patient we're working on at the moment, and I've called her canary in the mine because she has all the predisposing risk factors for developing Alzheimer's disease. And, as a clinician, I cannot ignore that because it's something that she's keen to understand. And we want to be as early intervention as possible. Next slide. So let's talk a little bit about her. She's 55-year-old postmenopausal female. Of course, as we know, Alzheimer's is more predominantly a female disease rather than a male. We think obviously there's a lot of that is associated with the loss of estrogen, particularly at menopause. And of course, she has gone through that period, and we're probably looking at an individual where estrogen is incredibly trophic for the brain. It's really good for the brain. And we think there's probably part of the puzzle that is that. So again, maybe there's an influence there of maybe some well-targeted hormone treatments may be part of this patient's protocol as we go forward. Her dad had Alzheimer's. She's got a 30-year history of IBS, and she's been hyperthyroid for 15 years, and she's medicated on levothyroxine. She's been very overweight, and when I'm talking about overweight, she was class 3 obesity, which is severe obesity, BMI of 40 plus, She had a mini gastric bypass in 2016 and she lost 6 stone. So an incredible weight loss. But she's still class 1 obesity. So she's still really quite a big lady. Just some other facts, again, her medical symptom questionnaire is her subjective view of how she views just basically how she's feeling, really high at 90, and she's mildly inflammaging. She's got a CRP of 3.8, so it's not crazy out of shape, but it's out of shape enough for us to think about it might be a signal. So look, let's have a look at some of her simple ongoing concerns and symptoms. She's increasingly got brain fog, and this is a patient who is a lawyer, so she's very clear that she's lost some of her brain function. I know that's a subjective view of it, but she's increasingly noting that her memory's not as good as it should be. She's always bloated, and again, just to put this in, she's a heavy snorer. Next slide. So dental information, again, really important, based on the big workup. And she hasn't been to the dentist for years. She was traumatized at the dentist as a child, and that's one of the main reasons. Her teeth aren't great. She's got lots of mercury amalgams. I noted 8. She obviously wanted to have a conversation because she'd read about mercury and Alzheimer's risk. And very simply, the best intervention that I gave her was to basically go to the dentist. Look, you're going to need to suck it up and you're going to need to go to the dentist. So she managed to do that, which is brilliant, massive step forward. She's got significant periodontal disease. There's multiple pockets, and when we mean pockets, we mean the way the gum recesses away from the tooth of 6 millimeters or greater. So really quite a lot going on, and there's several unstable teeth there that may need removal, and those pocket depths are nearly a centimeter deep. So it's a very significant problem there. But she's done the major step forward. She's gone to the dentist and she's starting work with a dental hygienist. Next slide. So I just, here's her gene results from some of the gene panels that we use. And again, there's some very significant results here. As you can see on there, she is ApoE4E4. And based on a molecular psychiatry paper here in 2011, that puts her lifetime risk just because of this gene association, around about 60% of developing Alzheimer's by the time she's 85. So quite a significant risk. Definitely becoming a bit of a canary in the mine, and we definitely need to look at this. And again, as you can see there, increasingly she's got quite a lot of pro-inflammatory gene SNPs. And again, just want to reiterate what that means is that we all produce inflammation, and inflammation is good because it's the start of healing. This is a patient, though, who may produce too much inflammation and actually may not switch that inflammatory response off quickly enough. And that's where the risk factor lies for these sort of genotypes. Next slide. So here's her first neurocognitive test. And as you can see on that, it's pretty damn good. So for A's and sex matched, she's doing really well across all parameters. Now, you can see the arrow there. And the only reason why I put this arrow, because this is the first time we've tested her. And so what I've got to be able to do is take her history. And her history here is my mind is definitely nowhere near as good as it was. And take this as the first time we create an objective line in the sand, because as you can see there, her composite memory, which is the sort of overall view of memory, it's okay, it's low average. And we're talking about a patient who, by the job and what she needs to do, was probably way higher. Now, we can't put an assumption on that. We can only go on the patient's story with regards to, my mind was so much sharper before I could remember much more things. So I don't know. What we're seeing is a patient over the years who's gone from very high function as far as memory and starting to be on the slide. But this is the first time we've measured it, and that means that we can monitor now going forward, and we need to stop the slide. That said, this is showing an overall picture of the patient with pretty good overall brain function. Next slide. So as you can see there, her oral bacterial test, the severity and the pathogenicity of the bacteria on the battlefield, we're seeing 2 high-profile results there. They need to be treated. Next slide. Her DNA SMART results here, as you can see, not so much the innate, the first line of that immune response, but very much the second line, the inflammatory and acquired, the part of the immune system that remembers and develops things. As you can see, there are lots of big SNPs. There are major SNPs on IL-1 beta and IL-6, as well as IL-17A, that of course not only predisposes for gum disease, it also predisposes for potential autoimmunity as well. Next slide. So I just want to give you some of the things that we also look at from this point of view that brings in the sort of mouth and the mechanics of the mouth as well. Because one of the other things that we know, she's a significant snorer, and generally the more overweight you get, the more likely you're going to snore, but the more likely you may be having low oxygen states at night. And that's quite important, because what we're learning is that certainly in the chronic fatigue field, certainly in the Alzheimer's field, we're seeing increasingly more evidence that people who don't get the appropriate amount of oxygen at night increase the risk of Alzheimer's disease. And so what we can do very simply is we can do a Mallampati score on any patient that comes in. So if you, Susan, if you give me the next slide, I'll show you. So this is very simply a Mallampati score. You look into someone's mouth and you can see how occluded the back of the mouth is. We're looking for patients that have class 1, where you can see all the architecture of the back of the mouth, because this is giving you an indication that there's much less risk of problems with airway problems. And as you can see there, class 4 is almost a complete occlusion, which increases her risk of sleep apnea at night. And she was class 4. So I was already thinking this is a patient who may be at risk of many disorders, certainly energy disorders, chronic fatigue, etc., because maybe she is getting low oxygen states at night. Next slide. And again, when we start looking at the literature, again, very recent paper looking at 3 decades of multidisciplinary research. And the conclusion again is that recent trends demonstrate links between sleep apnea and Alzheimer's disease biomarkers across all age groups. So this is not something that's happening in people who are in their 70s and 80s. This is happening across all age groups. Next slide. Now, one of the other things we've got to think about, I bring you back to bacteria, because as you know, some of the major mechanisms that might be driving an upregulated immune system, both running around your body, but also in your brain, is when bacteria translocates to other areas. So one of the things that, whether you're aware, there's a disorder we call SIBO, small intestinal bacterial overgrowth. And what we're seeing on that is that we see a lot of SIBO and we treat a lot of SIBO. And when you have SIBO, you have bacteria, you have abnormal amounts of bacteria just in the wrong place in the small intestine. Usually good bacteria, but it's a bit like having a design department in the accounts department. Really good people, but doing the wrong job and causing problems because of that. But when you have people with SIBO, you have much more increased risk of having a leaky gut. And what we see is, again, you can have significant bacterial overgrowth, both from a point of view of ear, nose, and throat, but also from a point of view of gum disease. And given that we're swallowing 1.5 litres of saliva on a daily basis, you are swallowing, if you've got active gum disease, pro-inflammatory cytokines from the immune response, but also some of these pathogens. And that might be one of the mechanisms, and certainly the evidence, there's 2 papers here, are starting to note, particularly the Cell paper of 2020, that we've got to think about gravity can move bacteria to other places and start to cause issues. So when we see people with SIBO, we also need to ask them about what's happening in their mouth, because if they're swallowing pathogenic bacteria and they're swallowing pro-inflammatory cytokines and they are getting through the stomach, then they can have problems in the small intestine. Next slide. Can you just, let me carry on with this one. Now, remember we talked about this patient. This is a patient who's had a gastric bypass. So when you have a gastric bypass, you have some very big wins, and she's lost a lot of weight, which is fantastic, but you also will have lifelong issues around the way your digestion works. And that's obviously problematic for this patient, because what that means is that she has a very restricted diet. And of course, that restriction of diet means that she doesn't have as much plant foods as she would like. And that's problematic, because we're learning all these post-metabolites that your bacteria make, and they make it because they love fermenting plant foods and the fibers. And we can measure there's metabolism of how well these bacteria are when we do stool tests, because we can measure the levels of short chain fatty acids that your bacteria are producing. I'm going to talk a little bit more about short chain fatty acids. And you can see here, our patient's just not producing enough. And that is problematic, both from a point of view of the local immune system in the gut, but also the immune system at the blood-brain barrier and the brain. Next slide. Next slide again, Susan. That one's shouldn't be there. And so one of the short chain fatty acids that we're talking about is butyrate. Quite novel in the literature at the moment, but butyrate seems to have this function where it sort of modulates the immune system. So it's modulating what's happening at the GI tract, it's calming the immune system, but it's also quite easily translocating up to the brain and is calming the immune response in the brain. So butyrate seems to be more and more of a player for helping patients with neuroinflammation, helping them resolve barrier function, both at the gut, both at the mouth, and both at the brain. Now, we're using a lot of butyrate with our patients, but butyrate is created by moving people onto a much better plant-based diet that are high in different fibers, because your bacteria love those fibers. And we're measuring those fibers in the stool. We're measuring how happy our bacteria are by how many short-chain fatty acids we're producing. So it does look like that we're starting to get this understanding about how things that your bacteria make in the gut actually have an incredible influence on not only just the central nervous system, but also blood-brain barrier integrity and calming actual aspects of your brain's immune system, like the astrocytes and the microglia. Next slide. Now, again, I don't know whether you don't have this piece of kit in America yet, but one of the key things we've got to do our patient, because she's snoring heavily at night, is to try and help her with regards to reducing the amount of mouth breathing that she's doing at night. There's two reasons why we want to do that. Because when you mouth breathe at night, you probably don't breathe and get enough oxygen in, but it also dries your mouth out, and therefore saliva doesn't get the opportunity to do its antimicrobial and antiseptic work. So if you're having patients who are waking up with significant dry mouths all the time, that's problematic for the progression of gum disease, because saliva is incredibly protective, and that's something that we need to think about. What we also know, again, is that you're going to have patients who maybe are on drugs that like diuretic drugs in particular, which means that these patients may be more prone to being dehydrated, and of course more prone to maybe not producing as much saliva as you'd like. And that has cross consequences with regards to the mouth. But the iCuro is it's a small piece of kit that you put in your mouth, and what you do is you pull it and you create all this sort of muscular work. What we've learned with regards to the reflux science, and when people have GERD or reflux, is that it's very rare that we're actually seeing patients with just too much stomach acid. What we believe is happening, and this is where iCuro has been developed, it's been developed by Scandinavian scientists, and in the National Health Service in the UK, they've literally just brought it in as a gastric reflux tool. What we believe is happening is that it's not that humans produce more stomach acid at all, is that what is happening is that the neuromuscular connection between the brain and the stomach and the sphincter muscles down the food pipe don't work as well. It's a little bit like we lose our muscle mass, we lose the capacity to our brain to talk to our muscles as we age, we atrophy. We think that is predominantly what is happening with gastric reflux. And what is happening is the signals aren't strong enough to the brain to close the sphincter muscles on the food pipe. And then what happens is that food pipe opens and you get the gastric reflux. The iCuro machine, we're using it with our patients to incredible success. We use it 3 times a day for 10 seconds with a 3-second rest in between. It's been brilliant. So it's not in the US at the moment, but you can definitely download and have a look at it online. iCuro.com is the website. Next slide. Now, I'm sure, I don't know how prevalent mouth taping is in the US, but this is definitely, again, something there is from a clinical, there you go, Susan's got him, brilliant. It's a clinical, and the iCuro, brilliant, well done, good stuff. It is when you're dealing with patients and you've got to do a lot of them, I'm always there from what is the low-hanging tree intervention that I can do that has good clinical outcomes, but also has very little investment in money. That is something to think about. And I've been hugely impressed by how mouth breathing and taping has worked. I was absolutely, I say 4 or 5 years ago, I used to think something like this was absolute nonsense. And I still think if you're going to just tape your mouth shut in certain circumstances, I don't think that's appropriate at all. But with this taping that we use, it doesn't really shut the mouth. What it gently does is just close the mouth. So you can, if needed, open the mouth. I've had really consistent and incredible success with this piece of kit. It's so simple. It's so cost effective. It costs buttons to use. And what we're doing here is we're allowing the patient to start to breathe through the nose rather than the mouth at night. It's been brilliant. So again, we reduce the risk of the oral disease. And when again, the work with Dr. John Roberts is that many people with gum disease that doesn't get resolved because you have patients, and you'll have patients who say, I do everything, but I've still got gum disease. And one of the mechanisms that might be driving that is that actually they are mouth breathing at night. And when you start getting on top of that, you start getting on top of the oral disease as well. So this is MyoTape, and you can get it online on Amazon. And I would highly recommend it. So if you have a patient who is snoring, Susan showing you the packet, the company is called MyoTape. It's brilliant. And I think we're going to see more and more research on this. There's a paper there in Journal of Clinical Medicine 2021. There is again, and that website also is giving you more evidence with regards to this might be the right thing to do. Next slide. So look, the reality of this is, and I probably slightly rushed it, so I really apologize because we didn't quite get the technology right at the beginning. And I'm absolutely happy to do questions. The reality is there's some really simple advice on this, and that is that actually we really do need to think about the mouth in a slightly different way. And you just really need to maybe think about your day-to-day way that you deal with your mouth as well. Next slide. So look, again, buy your oral gym membership. And so although this sounds a bit boring, this is, again, the low-hanging fruits with regards to the best case scenario and interventions is that maybe not so much regular dentist appointments, but absolutely regular hygienist appointments. There's so much technology. Again, listen, I'm not a dentist, but the amount of progression that's happening in dentistry from a point of view of no longer can dentists ignore the literature. You can't ignore the literature of how important the mouth is and the things that you do to the mouth. And this is a therapy, maybe I don't know if this is in the US, but definitely quite a therapy that we're seeing over in Europe is what we call guided biofilm therapy. And these 3 pictures show you that what the biofilm is doing is identifying more serious bacterial calcareous deposits on the teeth. If you look at the middle section, this makes it much easier for dental hygienists and dentists to identify more pockets that maybe they wouldn't see normally. And again, guided biofilm therapy, depending on the severity of the patient, is something that maybe is done every 2 months, depending on the severity, or 6 months to a year. And of course, good old physical removal from the hygienist is another aspect as well. Next slide. So again, I think a lot of this is that, I think about in my perspective, this is me. And to be honest, I find it incredibly boring that I've got to continue to do this. It's really dull as dishwater, but I appreciate what it's done for me. I appreciate that I've gone from sort of quite some severe periodontal disease to very moderate at best now. So again, thinking about, the classics from a point of view of, clean teeth for 2 minutes a day, twice a day, and use TP brushes. Again, the TP, what's interesting about TPs or flossing, and 30% of total plaque is actually between the teeth. So it really is, worth it if you can. Next slide. But again, as I take you back to a lot of these patients, it really is, comes back to the fundamental pillars of health, is that you've got to be doing things that promote an anti-inflammatory lifestyle. So you want to be taking consistent, moderate exercise. And I still, and what you might not know is my original background is an exercise scientist. I've got 2 degrees in exercise science. And what is great about where we are with exercise now is that exercise is starting to become more and more a player in general medicine. And I can tell you from obviously, knowing this area really well, nothing touches exercise as a modality for health. Absolutely nothing. There is no polypill that can come even close to doing consistent exercise. Now, there's a spectrum. Most people don't do enough. And then you'll have the other people where they do way too much and it all becomes pro-inflammatory. But consistent, moderate exercise is probably the biggest intervention you'll ever do for your health, as being closely followed by the nutrients and the diet that you choose to do. Again, very rich in plant foods, good protein sources, a rainbow of colors that are giving you lots of plant foods that give you lots of fiber and lots of chemicals like polyphenols, or some of the compounds that are coming out of olive oil are incredibly anti-inflammatory and protective. And you want as diverse a diet as possible, because the bigger the diversity of the diet, the more your microbiome, the bacteria, and remember you're more bacteria than human cells, the more they love. So the more varied the diet, the better. Next slide. Again, there are, maybe someone needs the iCura there. And there are situations here where lots of nutraceutical companies are now entering into the oral space. And this is dental siding from, I think it's Bio, I can't remember what the company that runs it. We've used this a lot. It's expensive, but actually it really does tend to do a really good job. We've really enjoyed, I like this product, but there are other products coming out and I'm going to show you those. And as you can see there on the liposomal oral care that we use a lot with patients as well, we're looking at localized vitamins and minerals and nutrients that are helpful in the mouth. So we know CoQ10 is a player, we know quercetin is a player as well. And we're also looking at the broad spectrum botanicals that are allowed to try and recreate an optimal balance of good and bad bacteria, but also try to start breaking down some of these significant biofilms. Next slide. This is an English company, In Vivo, and they have an oral probiotic mouthwash. We use this with our patients in the morning and in the evening. There's also research nutritionals that I'm talking to at the moment. They've just brought out a new product called AuraMax, which actually has got some exciting stuff with it as well. I'll be doing a podcast with them very soon, actually next week, to talk about their product, but also talk about oral health and general health. So everyone is coming into this arena, but they're coming into this arena because you can't ignore the science. The science is so overwhelming that it's something we need to think about. So this is an oral probiotic. So we use this for our patients once or twice a day. They swill it around after they clean their teeth and they swallow it. And what we're doing when we're talking about probiotics, we're into the realm now where we're actually looking at strain-specific probiotics to do a specific job. So I think we've gone past using probiotics generalized. What we're doing now is identifying strain specifics that do a job for us. So again, something like In Vivo or Research Nutritionals, they brought out nutritionals. Research Nutritionals have it's like an oral lozenge, and you suck it, and then it sort of dissipates in the mouth, and you leave it there. So again, we're moving into this area where we're trying to bring new soldiers to fight the battle. Next slide. Really interesting is that we're actually seeing that chewing the right gum may be helpful as well. So we know that xylitol and sorbitol may actually have good effects on the microbiome in the mouth. Interesting. And what's interesting about this is that we've used this on patients where I can think about a couple of people who are type 2 diabetics and smokers. And if you want to accelerate gum disease, then smoking is the easiest and quickest way to do that. And of course, but one of the key things with getting people off smoking is there's a habit forming and holding form. And so we've got to have something to replace the smoking with. And the gum seems to do that. And of course, it's another opportunity for us to use a particular gum to help the problem. Next slide. Now, again, I'm sure you're all aware of this, but there are antiseptic mouthwashes that have some chemicals in them that actually damage the bacterial groups. The main chemical is what we call chlorhexidine. And chlorhexidine, what it does is it kills some of the bacteria on the back of the tongue. And some of the bacteria on the back of the tongue, their job is to take the nitrates out of food and eventually create nitric oxide. And nitric oxide is this incredible gas, if you like, that is a sort of real healer, particularly for the vascular endothelium. So it keeps it really smooth. It stops things attaching to it. It's really important. It's even more important when we get patients like this patient of ours here, who has an enos SNP. Now, again, this is endothelial nitric oxide synthase. It is the enzyme that helps secrete nitric oxide on the vascular endothelium, and this patient is much more at risk of it. So you might have a patient who's having antiseptic mouthwash with chlorhexidine, damaging the nitrate changing bacteria in the back of the mouth, and therefore they're not getting enough nitric oxide, which is exaggerating this. And you might be seeing a patient that is increasing their cardiovascular disease risk, but also their blood pressure risk as well. Next slide. Here was our patient with her results again, and what's difficult to show on here is that actually she's doing really well. Her gum disease symptoms are getting better. Her porphyroid voice gingivalis is ever slightly getting under control, and we've got a little bit of an influence from Tannerella forsythia. I don't know why that happened with her, but what we were getting is that we were getting a degree of, and remember, she's only just done 3 months. She's very sensitive to the dentist, and maybe we just haven't worked with her long enough through bringing the porphyroid voice gingivalis down. Next slide. Yes, sorry. So this is her 3 months results. That test you saw there was where she was at the beginning. Here's her secondary results. And as you can see, porphyroid voice gingivalis is moving down, as is Tannerella forsythia, and she's got trepamina denticola, which has popped up. We don't know why. Again, remember, this is not a patient that we're going to solve in 3 months, but overall, she's doing well symptomatically. Next slide. So here's where she is at 4 months' time. And again, things take time. Patients, again, have to accept that if they're going to go on a journey, number one, they're going to have to change their life. Number two, it might take 3 months to even get an understanding of where the hell are we going, because what is the data telling us? What we've got to be careful with is that it's an ongoing process. But after 4 months, her dental examination showed no pocket depth above 6 millimeters, so she's doing really well. And there's less bleeding there. Her teeth feel more stable. But she's significantly doing well around the snoring. She feels less fatigued. I would assume that she feels less fatigued because probably she's oxygenating herself better at night. And she does perceive that there's less brain fog, and her brain has a calmer feeling to it. Now, again, they're subjective views. We haven't done her CNS vitals retest, but that's on the cards. Next slide. So, look, I'm going to summarize that, and I'm very happy to do questions because I know there's a lot in the chat box, and hopefully I'll answer everything that I can. Summary of lecture. I think it's clear that poor oral health influences Alzheimer's disease, but it also influences potentially the progression of other diseases. I believe that it's standard of care to at least ask the question about any patient about what is their oral health and how does that relate to potential some of their other diseases that they may be coming in for. If I take you back to that very recent paper that is looking at, we have this great opportunity because periodontal disease generally is for many patients can be happening quite early, late 20s, early 30s. and we want to get on top of that as quickly as possible so that we have that window of opportunity to help potentially the toxic effects on the brain that bacterial translocation may have on the brain. And then again, unfortunately, a lot of this is boring stuff, is that, you know, the success happens in what do we do on a daily basis. And so therefore, a consistent daily dental regime is needed and maybe needs to be a little bit more prominent. Again, for me, who has to do it all the time, I find it boring, but I've seen what it's done for me, and it's kept me from moderate to severe periodontal disease to actually a disease that I've got pretty much under control. I'm always going to have to do it on a daily basis because otherwise, you know, I have a genetic susceptibility. It's always going to be problematic, but I feel as though I'm doing a good job on that. So that's the end of the slides. I'm very happy to go to questions if I can answer them. I know there was there was one at the end with regards to, can I be clear about something? I might not have been clear on the patient, so I can't remember what that one was. So Susan, shall I try and answer some questions?
Yes, please.
Shall I just pick some of these?
Well,
So
why don't we go in order? Michelle, why don't you unmute yourself and ask your question?
Hello, Pete. My
hi
name is
there. How
Michelle.
you doing?
I'm doing great. Thank you so much. It was an excellent presentation. I'm not putting my camera because I had the emergency surgery and I'm recovering. Actually, the question I have for you is when you mentioned about the leaky gums, and the surgery I had, I was brought in emergency and I had a perforated appendix with everything, sepsis and gangrene and you name it, I had it. I had 2 CT scans done with the iodine contrast. And since then, my upper teeth on both sides, it's leaking. It's like my gums are leaking. I've never had that. I have a very healthy, you know, mouth. And actually I had all my mouth checked because I just had Invisalign made. They're going to be installed next week. And so I had like deep cleaning, all the x-rays. I saw all the specialists to make sure that, and I'm 62 years old.
Sure.
So I don't know if you ever heard of leaky gums after iodine contrast.
No, I think is the answer to that. That is a new one for me. I couldn't give you a mechanism of why that's happening as well. I think, I mean, are you feeling as though they're getting better, or?
Yes, they are, and
Okay.
it's like right after I had it once before the surgery, and then a week later after the surgery. I was in the hospital for 7 days, and plus I had to go back for complications. But, and also what felt strange to me is that my teeth felt loosened, like if they were loose after.
Yeah,
So,
really
but
interesting,
they are,
Michelle.
oh, yeah, they are now better. Well, they saved my life. I almost died
Yeah,
twice. So.
I don't have an answer for that, but whatever,
Okay.
you know, whether that is part and parcel of the surgery or part and parcel of some of the complications from the surgery, I honestly couldn't answer that. The good thing is it seems like it's settling down.
Yes.
I would definitely maybe just think about as maybe an insurance policy is just maybe a probiotic mouth swill for maybe a month, just to enhance that process. That
Wonderful.
would be,
I will do
that would be
I
my
will-
advice on that one.
Well, thank you so much. And I
Pleasure.
will really see your presentation when the recording is out. It was awesome. Thank you so much.
Thanks, pleasure.
Hey, Karen, next.
Okay, hi, thank you.
Hey,
Thank you so
Karen, how you
much.
doing?
Hi, good, thanks. And thank you for the presentation. It was very interesting. I wanted to ask about, you had mentioned probiotics at the end, and I've been using a product called Bliss Probiotics. I don't know if you're familiar with it, but it
I'm not,
contains,
no.
it only has Streptococcus salivarius in
Okay.
it.
Yeah.
So I just wondered, you know, what you think of that.
If I remember, Streptococcus salivarius is one that may be associated. Is that product more associated with the reduced risk of dental cavities? Are you? Is that what it's? Is that what it's for?
I don't believe so. I think
What is it advertised for?
I'm not sure what it's advertised for. I was thinking it was for periodontal disease, but
Okay.
I'm not
So if
sure.
it
I
is
heard,
again, there are many companies now coming. Again, I think I'll have a look at it.
Okay,
If you could send
yeah.
me the link, I'll have a look at it. But
Okay, I'll put the link in the chat.
yeah, and
Yeah, I heard the founder of the company interviewed by Dave Asprey
Yeah.
maybe about a year ago.
yeah,
And he also makes a product for strep throat that he says
Right.
they've been using in developing countries where they can't get antibiotics easily.
interesting.
And it's working incredibly well for strep throat. It's a different bacteria, I believe.
Yeah, you know what, the supplementation industry is sometimes as bad as the pharmaceutical industry from a point of view of quality control is rubbish. So the probiotics aren't there in anywhere near the amounts that you want. So I think you better be careful on your choices on that. And there's not really a huge amount of products that have been directly tested in research studies with regards to our product did this. I do think that is increasingly happening now, because I think medicine is moving to the point where, oh, okay, well, maybe let's try this product. So I know someone like Research Nutritionals. A lot of their products have been done in clinical testing, actually using their products. Pure Encapsulations is another make, again, same thing. So there's there are some brilliant nutraceuticals companies out there. But I think there's always a bit of caution. I think you always need products that are, they should have a GMP approved certification. There's a couple of other certifications in the US as well that they have, which is showing that what you're getting exactly what it says on the tin. But you will be surprised.
Do you want me to send the link to?
Yeah, if you send it to me, that I'll have a look at that at a later date, and maybe I can correspond in some way, shape, or form in the future.
Okay.
On that one.
So, and what email address would I send it to?
So if you can send it directly to me. If you send it to Pete and I can give this out, Pete at fm.associates.
Okay. And then I just have one more quick question, and I don't know if you mentioned this during the presentation because I wasn't here for all of it, but I wondered about cavitations. I know you talked about periodontal disease, but I know that, people with cavitations also have a buildup of bacteria, and I have been diagnosed with cavitations by my biological dentist. He suggests surgery is the only option. But I spoke with a friend who is a biochemist, and he suggested using DMSO, just rubbing it on my gums, because I get pain like maybe a couple times a month.
Sure.
And when I use DMSO, the pain goes away. And I don't know if it's just addressing inflammation or whether it's actually killing bacteria, but I'm much better in the past couple months since I've been.
So I'd like to.
Yeah,
so that's not a product I'm aware of neither. And again, and maybe this is disparity between Europe and the US.
Okay.
I think it becomes a bit like, that conversation I had with regards to should everyone have their mercury amalgams taken out, and as a blanket, absolutely. But then comes the nuances. Well, how are we going to do it? Is it going to be done well? Is it going to be extracted well? And then what do we put back? And then suddenly you're like, people don't recognize that, maybe that it is the mercury amalgam that's holding the tooth together. And as soon as that's gone, you're going to have to have a whole new tooth, and that means a whole new implant. And there's, you start moving into tens of thousands of pounds worth of advanced surgery, and implants have very significant failure rates. So it's this sort of nuance about, right, okay, so what do we do? So that's where Dr. John, again, I mean, this is not my area, but someone like Dr. John Roberts is incredible from a point of view of saying, maybe there's a long-term strategy where we need to do X, and then think about this, and then think about that, and think about that. So again, it's a real nuance. I see the same with root canals, same thing. Do you take it out? Do you put a root canal in? And I don't have those answers. And again, I think more that's where I think biological dentistry is starting to do a better job on that side, on trying to answer that. Again, it's a whole new world that came up for me. I got into this because I wanted to understand as a clinician, when people are coming in for obesity, type 2 diabetes, rheumatoid, wow, look at this link. and how do I learn more about that? So it's a very nuanced area, but definitely a hugely expanding area as well.
Okay.
And I think it's the IAOMT, is it? In the US, that's the big, I don't know whether they call themselves biological dentistry or not, but they seem to be doing some really good stuff, some good stuff on that one.
I would like to make, oh, sorry.
So someone just put my email up. It's fm.associates, no.com.
I would like to make a comment as well. Cavitations can very heavily increase inflammation, oxidative stress, etc. One other approach to consider is drilling into the bone and injecting ozone. I had trigeminal neuralgia and chose at least the most benign pills I could find. And drilling into the bone and injecting ozone cured my trigeminal.
I did ask my dentist about. Yeah, I did ask my dentist about ozone, and he said, well, it was something that would need to be done every few months or maybe just a couple times a year. And the expense is pretty high. I thought I'd be better off saving my money for the cavitation surgery, but the DMSO is really making a difference. And I just don't know if it's, killing the bacteria enough that I won't have a possible complication of Alzheimer's down the road if I have those genes for it.
I mean,
I just don't know the mechanism of action there.
It's really interesting. I don't know. I think it's the answer to that.
Okay.
But this is great because I'm learning loads off you guys as well. So that's fantastic. Someone said again with Suzanne, does the Invisalage, which I think is the gum, the mouth shield, would that affect gum disease at night? It's a really good question. I suspect it might increase the risk of a dysbiosis. I suspect, I don't know, but I think again, anything that maybe alters the way you breathe, I certainly think, and if you are using it at night, may be problematic. Anything that pushes you to maybe open your mouth and mouth breathe, I think is going to be more likely problematic. I don't know if there's any science on that, but that was the logic that would make sense. And I think if you are going to use a mouthpiece at night, then maybe the myotaping as an insurance policy, I think would probably would be quite helpful on that side.
Mona, your question.
Hi, can you talk a little bit about the frequency of meals and how that affects things? For example, some people find that inflammation seems to reduce if they do one meal a day versus some people find that blood sugar is better if they graze more frequently.
You know what, Mo, it's a really good question. So I'm going to answer that with regards to just purely to gum disease and the people that I've dealt with. I suspect less frequent meals are more beneficial. And I would say that simply because most people with reasonably advanced periodontal disease always get food or particles caught in those pockets, and that becomes part of the irritation. So again, I don't think there's probably research on that, but from a practical perspective with the patients that I've been with, it seems to do many good jobs. It helps them generally eat less calories, which is usually mostly beneficial for most people, not all. And it seems to reduce irritation, so on already inflamed gums. So I think from that perspective, yes, I would suspect so. But of course, you're going to have some people who have lots of other conditions, like many people are predisposed to hypoglycemia. And so if they're not eating something every 3 or 4 hours, they've got all those problems. And again, I think it's just a question of taking that into account. But I do suspect, I think sometimes the information about 3 meals a day and 2 snacks was the worst thing I think we could probably have ever given people. I think 3 meals a day and sticking to that, I think is a solid thing to do. But I would also suggest that, again, with the type 2 diabetics and the type 2 diabetic patients with the significant gum diseases that we've dealt with, moving them to 2 meals a day just really, again, these are people who are just consistently irritated. They've got food. They're always fiddling with the gums, which can, again, because they feel as though they've got food particles caught in there, and it really becomes a bit of a pain. And in our experience, 2 good meals a day have been much more productive for them. But of course, those two meals a day have to have as much of the good stuff in them as possible. So, I don't think it's a question of just sort of doing that because you can reduce calories. If we're going down to 2 meals a day, we're working hard to make sure that the quality of those 2 meals are enhanced. But it's a really good point.
Thanks. Can I ask a follow-up?
Yeah,
so there is some research about each time we have a meal, it changes the pH of our mouth. And that's one reason that people think that fewer meals might cause fewer events where the pH goes off and then has to be restored. Have you seen any data about mouth pH with regard to the mouth biome?
No, I haven't. I would love to see it. Again, it's just something I've never thought about. I think, one of the things that I do think about a lot is, and we mentioned this before, is all the patients that we see who are on drug therapy that changes saliva production, particularly the diuretics. And so when we have a patient with who whatever they're coming in for, who may be on a diuretic medication, we're always clear to ask the questions about the mouth on that side. Because definitely there's a relationship with and that's quite well known in the literature. So saliva is, again, I like everything, you think you know everything, and you know very little. And I remember just learning about the compounds in saliva, absolutely incredible fluid with just such huge protective proteins in there. So really, again, it's incredibly protective. So yeah, so no, but that's what I think about from a point of view of that. But anything that alters, as you say, the microbiome of the mouth, anything that reduces saliva function is likely to be more problematic.
Donna Lee, your question.
Hi, I had an infection in my mouth and my dentist gave me, I'm pretty sure it was chlorhexidine. I have a huge bottle of it.
Yeah.
And I just wanted to be clear. Did you say that kills all the good bacteria?
Yeah. So let me just explain about that. I think it's a bit like, I'm a massive fan of using medication in the right situation. Now, if you had a big infection in your mouth, chlorhexidine was probably the right choice. But what, as you say, an antiseptic has chlorhexidine in. What chlorhexidine seems to do is that we found that at the back of the tongue, we have bacterial species that help to take the nitrates out of foods and start to help the process of developing nitric oxide. So when you have chlorhexidine, you do kill those bacteria on the back of the mouth. So you lose that capacity to maybe gain nitric oxide from your foods. How long that goes on for, I think, is only of the duration of the use of the antiseptic. But, and here's the big but, is everything in medicine is cost, rest, benefit. And so based on that situation that you've just talked about, it makes absolute sense that for a period of time, that was the right thing to do. So what I would have done on that, again, and I think this is a bit like when we have antibiotics thrown at patients, is that you want a 2-pronged strategy. The antibiotics usually are life-saving, but what they're not taking into account is that what's going to happen in 3 months' time. I see this in UTI infections. I cannot tell you how consistent it is. The antibiotics deal with the bacteria, but they kill everything else. So 3 months later, so you leave an individual generally dysbiotic. And then in three months' time, the dysbiosis levels build up and the symptoms come back. So what I would have done in that situation is probably look to have something like a beetroot juice to run on a daily basis, or just have beets on a daily basis while I was doing the chlorhexidine, and have one away from the other. So that for me is a bit more joined up medicine that makes sense. I'm a big fan, as I say to you, in that circumstance that you said, absolutely makes sense that you were given that. Because no, I doubt, and don't get me wrong, I think it's the severity of the infection. It's a little bit like if I go outside tonight and get knocked over by a car, no amount of arnica that I rub on me is going to save me. I need acute care. And so that's why, again, it's sort of situation specific, and you want to modulate that sort of best of medicine, but also make sure you understand how are you going to use it for and what's the backup that we can use to offset it.
So you would drink the beetroot juice every day while you are doing the hexachloride?
Yeah, look, I think that would be a very robust strategy. I'm not suggesting you need to do that every day. And of course, but again, I think this is sometimes when it's great that you can gather genetic data from people. You know, if also I would be in that situation. I would, first of all, I would want to know whether we've got a patient with blood pressure issues. Because obviously the nitric oxide is incredibly, one of its other roles is that it relaxes that vascular endothelium, so that vascular tension gets reduced and relaxed, and of course that reduces blood pressure. So we know that nitric oxide is involved in blood pressure reduction. And so, you know, even when you're saying your situation, imagine that you were a patient who was a hypertensive patient having that done. It might not be that you need to use beetroot to offset it. It would be a good thing to do. It might be that actually, you know what, we're just going to follow your blood pressure as we do this. And if we see any movements forward or high with that blood pressure, then maybe that what we're seeing there is the problem there, because it might not be.
Thank you.
Does that make sense?
Now I'm reading questions from the chat. Anna asked, how can we test and how long will it take before DNA Smile comes across the pond? So I'm afraid this is not my fault. This is the fault of the distributing company. So they are already in the US. I think they are called DNA Life, but they haven't got off their butts yet to be able to bring that into the US. So Anna, if you want to again send me an email on this, and maybe we can push them to send a test out, or certainly get you on the course to get a better understanding. And again, the course is cheap as chips, and you can do it in 6 hours, and that 6 hours gives you just a good understanding of how you would start to utilize it. And I think just keeping the fundamental basics on that side. So yeah, if you send me an email on that, we'll see whether we can hook you up with the European distributors, who have been probably a little bit too relaxed with regards to getting on with things. But I think the reason why they are is because this is so new in medicine. It's difficult to get a lot of uptake currently because it's sometimes a little bit too far ahead of the game. And so we're struggling to really gain traction at the moment. But yeah, send me an email, and we'll see whether we can sort something out from there. Next question is there a link here with Dr. Raymond Perrin and his lymph system drainage in the brain and the body?
So I don't know his work, but I think if we're talking about the brain sort of lymphatic system, the glymphatic system is hyper dependent on sleep. So anyone who's not getting enough sleep is not going to have, and I think what we've learned is that your brain actually really reduces in size. It almost like squeezes down at night to expel things out of the cells. Kind of cool. But if you're not sleeping well enough and you're not going through all the phases of sleep, then your capacity to remove the rubbish from the day before is compromised. And that's definitely, we think, a problem with regards to increased risk, not just of neuroinflammation, but also potentially of Alzheimer's as well on that side.
Excuse me, sorry. May I say here, he's at Manchester University, I think both of them in some capacity. And he's working with people with chronic fatigue syndrome and making a major difference, including some astonishing cures. So he's worth checking out.
Absolutely. If you can send me a link, that'd be awesome.
I'll do that.
As you say, I mean, the sad thing about all of this is that there's so many brilliant people out there that you just never get to know all of them, and they're all doing amazing, and most of them are doing amazing stuff. So that's really helpful. Yeah, thank you.
We'll have your email address.
I've put it on. If you see it there, it says PW. There's my personal email address. Peter.fm.associates. There's no .com at the end.
Sure.
So that'd be great.
Associates. Okay, will do.
Thank you very much.
There's a question here, eating probiotics or eating to increase beneficial bacteria such as Akkermansia or mucinophilia. Does that help?
Good question. I suspect it would. Of course, Akkermansia seems to be we call it the gardening bacteria, is doing one of the most fundamental jobs with regards to keeping that sort of mucus layer really robust. Interestingly, I heard that for some people, and again, this is from the microbiome company in the UK, some people may be genetically predisposed to lowered Akkermansia levels. But what I would say I suppose it would depend on the probiotics that you're taking. If we have an understanding of probiotics, they do not take up residence. So we're very clear on that. So if you're going to use a probiotic, it is not going to take hold. It hangs around for about a week, maybe a little bit longer before you poop it out. So I think about probiotics as extra policemen that come in and help trouble. I think if I was trying to proliferate, and again, so it really is strain specific and dependent on what you want it to do. So I don't think there'd be any problem in taking a multi-strain bacteria, because I think you cover quite a lot of your bases. Generally would probably be helpful. If you're starting to look at specific bacterial strains for specific conditions, then that's when you start getting into strain specifics. I think I would be more interested in prebiotic formulas to help. So prebiotic formulas I see as superfood for your own microbiome. Probiotics are more from a point of view of helping to reduce trouble while you're trying to get your own microbiome up to speed. Because our microbiomes are essentially, your microbiome signature is essentially built by the time you're 3 or 4 years of age. And it ebbs and flows slightly throughout your life. And depending on, whether you've had multiple rounds of antibiotics or other things, it can stay in most people quite stable. So when you take a probiotic, unless if it's just a well-rounded probiotic, it is generally being utilized as policemen who are trying to modulate things. They don't take up residence. So I think if you're trying to increase your microbiome quality, I think prebiotics are probably better. But I think it comes back to, there's nothing like a very diverse plant food variety for doing that job. So, but what we do know is that we can definitely test about how healthy and how well your own bacteria are working, because you can measure short chain fatty acids. And it's the short chain fatty acids, particularly butyrate, that we're coining now a postbiotic. And so your bacteria, your microbiome are producing these post-metabolites from the ingestion of plant foods that are producing these postbiotics that are traveling all the way around the body and calming things down. So we definitely know butyrate does a really good job of this, of actually calming the brain in certain situations. So, but again, you can use prebiotics to help with that. You may use targeted probiotics, but also, again, this is where we bring it back to, if your diet is getting consistently better and fuller and more diverse of plant foods, you generally will start to have a more robust microbiome.
Next question is, what about if you wear Invisalign at night? That's kind of plastic dentures.
Yeah, so I answered that one before, and I think what makes sense to me is I think any foreign object in the mouth may increase your risk of dysbiosis. So I'd have to think, I don't know if there's any research on that. It makes sense that it may increase your risk. What's really interesting about this is because I was thinking about the same thing about a week ago. So I don't know. I suppose if you've got something foreign in your mouth, are you going to change the way you breathe? Maybe your mouth breathe more. If you certainly do that, it may definitely increase the risk. But again, I don't know if there's any research on that to look at that. It's an interesting question. I can find out.
There's a question asking if you could speak to the process for general evaluation that you would recommend. It sounds like you have a questionnaire and DNA testing and maybe some other labs as well.
Yeah, I suppose the question on that is that it really is dependent on what the patient is needing for us to do. And then also, again, it's probably slightly different to, I mean, I don't know how it totally works in the States, but we are a private medicine company only. So it's not something that you can do on the National Health Service here, the work that we do. That said, we are, I've always been a sort of, what is the low hanging fruit that is going to bring us the biggest returns? So it's very difficult to know what we need to test for and what we need to test for at the appropriate time. I think if I can give a criticism of functional medicine, and I don't think it's a criticism, I think it's a question of the longer you do it, the more you recognize that at any one time, you have a patient that maybe only has a certain amount of finances to put to testing at any one time. And I think what you've got to be able to do is you've got to be robust with regards to when you're building a program with someone with chronic disease, it's not something you're going to change around in 3 months. And it's not something really that you're going to get them free of their diseases in 6 months. So they've got to accept that you could be working with them for 2 years. But I think as a clinician, you've got to be really robust with regards to what do we absolutely need to look at now from test data, and also what are we going to need to do in 3 months, 6 months, 12 months. I think if I can see the mistakes of quite a lot of people in this arena, they over-test because it's kind of cool to look at and then don't know what to do with the testing. And the reality is, so I'll give you an example of that. Let's imagine you do a stool test at the beginning. Well, if you put them on a dietary intervention, that stool test is going to look completely different in 3 months' time. So I think an experienced practitioner, what they will be doing is saying to their patients, look, here's what we need to know now. Here's the strategy we're going to build. Here's the length of time frame that we need to utilize that strategy to see how well it's going to work. And here's the test, retest. Now, from that, we can start saying we need to do X, Y, and Z. I see too much out there where they are throwing thousands of pounds at just inappropriate testing, not because the testing isn't good, it's just completely at the wrong time. And you're going to have to do that test again in 3 to 6 months because it's been inappropriately strategized within the bigger picture of what that patient is. And unfortunately, what happens then is that you're thousands and thousands of pounds down the line. And so we've been acutely aware of that because we've had, you know, I've had over 2 decades to be able to work that off myself. And look, I'll be absolutely clear, right at the beginning, 20 years ago, it's kind of cool that you have all this technology. And so maybe, you know, I've been guilty of that in the past. You know, maybe I've over-tested people because, you know, I want to see all of this and I want to see all of that. And I probably wasn't experienced enough. But I look at it now and we're acutely aware of how much people, you know, have to spend. And I think this is a major criticism of the Bredesen protocol. I think it's an incredible protocol, but it's incredibly expensive as well. And I'm not so sure you need all of that testing. Certainly, I would disagree. Well, that's the wrong thing to say. Data is data. The more information you have on your patient, the greater you can do things. But you've got to balance that off with the practicalities of, I have a patient maybe that we've got to take him through this protocol for the next 2 years. And so they have all those costs associated with, you know, my consultation time and what we need to do. And I think what he has to do is he has to come up with what we call a Bredesen light. Because I think there are significant changes that you can make with people with much, much less intervention. That would be my way of looking at it. And that's been our experience. Every time a patient has come to us, and Susan, I discussed it at the conference in London when I presented. Most people have absolutely no idea what they might be getting into when they come. It's just that they've heard that there may be a cure, and most of them haven't even read his book. So, you know, when those patients come in, the first thing we say is that, well, have you read his book? because his book at least outlines a lot of the testing and a lot of stuff that may need to be done, and most of them haven't. And then when you get into how much is this going to cost, you go, wow, this could be just completely prohibitively expensive. And so what I've looked to do over time is go, okay, so on this unique patient, because although what President does, he uses a recode system. I think that recode system has been built for clinicians who aren't systems medicine trained, because it gives you a good template to utilize. I don't utilize the recode, and that is because, as I said, if I stuck to the recode, I might be doing an appropriate test that I'm not so sure my patient needs. And this is the balance with regards to, well, that's all great, and we need that, but my patient just doesn't have that sort of money. And actually, maybe they don't have to spend any money on any testing, because we can spend the first 3 to 6 months just changing some of the fundamental basics of their lives and see where we go from there. And then maybe we can intervene with testing. So there's lots of nuances, I think, that goes with it. And that's not being critical of the Bresden protocol. I think Dale would say absolutely the same thing, is that, to help more people, we've got to think about how we can do a Bresden light. I also think on that as well is that I think another criticism, I think, of systems medicine and functional medicine is that patients are coming in there thinking that they're going to do a new test and they're going to be given a supplementation regime, and everything gets sorted out. And therefore, it's almost like permission not to deal with the other stuff. And I think that is a really strong and robust conversation that needs to be had with every patient at the beginning, is that it couldn't be any further from the truth. And, when we're talking about supplements, and patients may spend up to, gosh, we've had some patients spend $1,000 a month on certain supplementation. But I think, that doesn't need to be done if they're doing the right things. And again, as you say, I cannot tell you I don't know whether it's because, and I think that this is where you get into the sort of psychological parameters for people to change. You've got to have that understanding that maybe for some people, just doing the supplementation regime is the best that they can do at that point. And at least that's making some degree of progress. I think where it gets a little bit tricky is that they're expecting that to change the world. And I don't see that. You've got to build, I think supplemental is supplemental to the bigger picture of the program. And they've got to buy in to making lifestyle changes. Because I do not believe that there's anything more powerful in the literature than some of those basic lifestyle changes. And I would say exercise is absolutely one. Sleep is the other. And again, changing your diets and changing the way you interpret the outside world and deal with other people. I think the stress levels, again, are, there's 4 pillars already that if you can get on top of that and make major progress, that is going to reduce some of the major aspects that go with everything that we've talked about today. So, again, we've had patients there. We're almost doing a real Bresden light. We've had patients that are absolutely full on with a lot of data that is being hugely successful. It really depends. And I'd say the success and failure for us usually is down to whether the patient is committed enough to make the changes. That's where I think the failures are. And again, through no fault of their own, because I think what conventional medicine has done for us is put us into a situation where you go to the doctor for a condition, you're given a medication, and that's sort of job done. And although we have a different way of looking at people, most people, through no fault of their own, because you've been indoctrinated in that, come thinking that they'll do a test that will tell them something about their brain, and they'll give a supplement, and that will change them. And so they still have that sort of old style conventional medicine thinking to a new paradigm of how you've got to look at people. So it's no one's fault. Again, you can get frustrated as a clinician, and patients can get frustrated as well. But I think we are definitely making a lot of progress in this.
So
any other questions?
Question.
Any other I can answer? No,
oh,
Suzanne's
hi,
just.
Hi, Pete.
Hi there.
I do have a question for you. It was in the chat, but I think maybe it got overlooked. What do you think about ozone machines? Like
Do you mean ozone for dentistry?
Well, no, the ones that you can get at home, like there's one called the O3 Elite for at-home use.
So I'm not an expert on ozone at all, so I couldn't really give you opinion on that. I know a lot of very highly qualified dentists are using ozone more and more from a point of view of dentistry. I certainly think from that perspective in dentistry, it definitely seems to be a player. I couldn't comment on basic health. I just don't know the research enough to give you a good enough answer. So I apologize for that.
No problem. Fair enough. Thank you very much. It was a great presentation. Very
Pleasure.
useful. Thank you.
Well, if there are no further questions, I would like to thank you, Pete. This is fantastic.
Pleasure.
Just feel very fortunate that we met and that you were able to share this information.
Well, I'm sorry that we had the hiccup at the beginning. Two technophobes don't usually go too well, do they?
Yeah.
Well, thank you, Pete. Thank you, Pete and Susan, for hanging in there. I really
I cannot tell you how I was literally shaking that first 10 minutes. I thought, oh my God, I sort of, and my technophobic aspect was panicking about it all day. So I was on much earlier and I thought, oh no, new computer, it's not letting me in. And I just don't know what to do. And I was just stood there thinking, God, everyone's turning up and here we are. Anyway, we got there in the end.
You just passed the hero's journey.
Well, yeah, I think a nice cup of tea and a relax after that would, I think is. But I am being interviewed by Research Nutritionals, which I don't know whether you know. They're a very big nutraceutical company in the US. They're just about to interview me for their podcast, I think, on their new oral product. So I will be definitely giving them. That they'll be interviewing me. I don't think it will be as detailed as we did today, but again, that will be out at some stage.
I'm also going to
have a newsletter.
Do I have a newsletter? Do we have a newsletter? Is that what you're saying? Yeah. And look, what I'll do is I'll link in, if I can just link in our website, because the full presentation that I did in London that Susan attended is on that. You can sign up for that full presentation. Ooh. So if I just if I can give you that now, I'll put that in the box. That gives you our company, but let me just copy that. On the front page is a link that you can sign up to the full presentation that I delivered at the London conference. So I'm going
to give you a copy of this recording, and I'm also going to ask you to be on my podcast. I had jury duty and couldn't schedule, so now I can schedule.
Right. I have. Let me just see if I have. Let me just get that. Edit again. So how do I pop this into the? Can I just pop a message in there? It looks like I'm sending one just to Richard.
No, you make on the very bottom, make sure it says to everybody and then pop in, because otherwise you're sending it to the last person that communicated with you.
Everyone in the meeting. Okay, here we go.
Everyone, and then we're all.
Right, so there's my website. On the front page of that website is that you can sign up to the full lecture. And I think obviously, I apologize for being ever so slightly, I probably rushed it to some degree today, but that presentation is nearly 2 hours long, and it really goes into slightly more depth with regards to some of the nuances that we talked about. So you can literally sign up to that free of charge, and you'll see where you can sign up, and you'll see that lecture presentation that we built there.